Lipids Atheroma, Evolution of Science, Learning from Statin Therapy-Based Trials. So we all know that atherosclerotic cardiovascular disease is the leading cause of morbidity and mortality throughout the world. Because there have been exposures to multiple things which are responsible for this: hypertension, diabetes, stress, use of tobacco, hyperlipidemia. Of all of these, I think the LDL cholesterol and other apoprotein B containing lipoproteins have been the most extensively studied, and they have been directly implicated in the development of atherosclerotic cardiovascular disease. Cholesterol is transported by apoprotein B containing lipoproteins in plasma, and LDL particles constitute approximately 90% of circulating apoprotein B containing lipoproteins in the fasting blood. Now, coming to the pathophysiology of atherosclerosis, there is retention and accumulation of cholesterol-rich apoprotein B containing lipoproteins within the arterial intima. LDL. Yeah, fine, I'll be all right. Yeah, thanks. LDL and other apoprotein B containing lipoproteins are less than 70 nanometers in diameter, so they very effectively enter and exit the intima. Now, we all know that physiologically relevant levels of LDL cholesterol are in the range of 20 to 40 milligrams per 100 ml. This is based on levels that are seen in the newborns, and even certain mammals have only these levels of LDL cholesterol, and they are what is physiologically relevant. Now, increased concentration of LDL cholesterol increases the probability of intimal retention of LDL, and this is progressive and in a dose-dependent manner. So, just schematically showing this, you have influences of diabetes, hypertension, tobacco, stress. They result in endothelial dysfunction. As a result, there's an increased permeability of the intima, and once that happens, LDL cholesterol enters into the intima. Once it enters, there is recruitment of inflammatory cells. Inflammatory cells ingest the LDL cholesterol, form into foam cells, and also this stimulates the multiplication of vascular smooth muscle cells, at the end of which this is what we get, a stable plaque. You have a thick fibrous cap, you have a atherosclerotic plaque with a lipid core, fibrous tissue, and smooth muscle cells, and this is what is a stable plaque. Now, there are different stages of these plaque formations. They have been classified into type 1, which initially a very minimal thing. You have isolated macrophage fill foam cells. You have a type 2 as a fatty streak, where there is a mainly intracellular lipid accumulation. Type 3, where in addition to fatty streak, we have some extracellular lipid pools. And atheroma lesion, you have fatty streak, and the extracellular lipid has become quite core and large. That is then you have a type 5 atheroma lesion, lipid core, fibrotic layer, or multiple lipid cores and fibrotic layers, or mainly calcific or mainly fibrotic. And then you have the complex plaque, where there's a rupture and gives rise to a hematoma or a hemorrhage and a thrombus formations. Now, for a long time, it was felt that most of the acute coronary syndromes were due to rupture of plaque of very small plaques, and the rupture of this would lead on to an acute coronary syndrome. But today, with a lot of imaging studies, we know that it is not these small plaques which rupture. Generally, there is a rapid growth of these plaques over 8 to 12 months, and these are the plaques which rupture. So, growth or progression of these plaques is essential prior to its rupture. Then some other thing that we need to understand in this is there's something called the Glagovian phenomenon. Initially, when there is lipid accumulation, there is no compromise of the lumen. The actual arterial diameter increases, but the lumen remains the same. So that is why angiography does not pick up all the patients where there is initial plaque formations. And when the ratio of the plaque burden to the lumen is around 40%, and after that you start lumen getting compromised. Now, 10 to 20% of non-culprit plaques generally tend to progress. Now, what are the factors which predict progression? Large plaque burden or high-risk features like a thin cap fibroathroma, low attenuation, and positive remodeling are predictors of progression and rupture of these plaques. Now, LDL cholesterol variability is an independent predictor of cardiovascular events. Now, evidence over last 30 years indicates that dose-dependent log linear association between LDL cholesterol exposure and the risk of atherosclerotic cardiovascular disease. If you look at it, what it means is that whatever be the level, a prolonged exposure to these, the longer you are exposed to it, at the end of it, the risk increases. So at a level of approximately 125 milligrams per 100 ml, by 40 years, you have a 1% risk. And by 80 years, you have almost up to 16% risk. So essentially, it means that we need to start tackling these LDL cholesterol levels and bringing it to a near normal levels or below normal at a much earlier age. And that is going to help us in trying to prevent progression and at the end, as a result of it, atherosclerotic cardiovascular disease. There are a lot of evidence to support these. You have these genetic studies where you have loss of function genes for apoprotein B or loss of function of LDL receptors. As a result, LDL cholesterol increases. Patients with this have a higher chance of atherosclerotic cardiovascular disease. You have prospective epidemiological studies also where they have followed up people with high LDL levels over a period of years and found that the incidence of atherosclerotic cardiovascular disease is higher in them. Then you have Mendelian randomization studies where there have been certain genetic changes which patients have got lower levels of LDL cholesterol. When they are compared with their siblings who do not have that gene, you find that the incidence of coronary artery disease is much lesser in people with low LDL cholesterol levels as compared to people who have got no or higher LDL cholesterol levels. Then the most important, we have number of randomized studies where more than 150,000 patients have been included in these studies, and I will tell you the details about that shortly. So what evidence do we have from randomized controlled trials? The effect of therapies that reduce LDL cholesterol on the risk of cardiovascular events, and by noting that down, we have been able to confirm the fact that they are responsible for the atherosclerotic cardiovascular disease. Meta-analysis of 26 statin trials, almost 170,000 individuals with statin treatment, and they found that there's a log linear 22% proposed reduction in the risk of major CV events per millimole per liter reduction in LDL cholesterols over a mean of 5 years of treatment. This effect is independent of baseline LDL cholesterol, meaning that whatever be the LDL cholesterol levels, you bring it down further, we are still going to get benefit as such. So even at levels even below 70, below 50, we have still found that when you compare the different levels, we are finding benefit in those patients also. Reducing plasma LDL cholesterol by inhibiting HMG-CoA reductase with a statin leads to a dose-dependent reduction in the risk of major cardiovascular events. Now, these are the meta-analysis. Here you have two groups, one where it is more and versus less statins, and one statin versus control. So if you look at any major vascular event in this study, if there are 5 major studies where there were more versus less statin, you find that there was a reduction in major vascular events about 4.5% versus 5.3%, coming to approximately 15% relative risk reduction. And between the two groups, there was a difference of almost 0.5 millimoles per liter cholesterol, which is approximately around, in the unit that we use, approximately around 19 to 20 milligrams of per 100 ml cholesterol. So that with that difference, this was the difference in terms of event rate. Then in the other group, the larger group where it is statin versus control, in them also for any vascular events, 3.2% in the patients who received statin, and it was 4% in patients who were the control patients. In them also there was an approximately 20% relative reduction of atherosclerotic major vascular events in this. Now if you look at individual vascular events, you find that the group with more versus less statin, non-fatal MI and any death, there was significant difference. If you look at incidence of bypass and angioplasties, also you find that there was a 2.6% and 3.2% incidence. When it comes to stroke, also there was a combined difference. Though ischemic stroke, there was a significant difference, while in terms of hemorrhagic strokes, there was no significant difference, or in some of the studies they found that there was a non-significant trend towards increase in the hemorrhagic stroke. Then again, when we compare this, you find that with every 1 millimole reduction of the LDL cholesterol, that is about, like I told you, 1 millimole is about 38 milligrams, in all categories of patients, be it patients with previous vascular disease, with diabetes, without diabetes, male, female, different age groups, people with hypertension, people with smoking. In all the groups, reducing these LDL cholesterol gave them benefit in terms of reducing their cardiac events. And like I told you, whatever be the level of LDL cholesterol, further reduction. So if you compare it even less than 2 millimole, that is in a patient less than 70 milligrams, more than in all groups, by reducing LDL cholesterol, we do get clinical benefit. So we have still probably, that is why with every passing, guidelines, you find that the LDL level that is being targeted is becoming lower and lower over the progressive years. In terms, of course, there has been some concerns about non-vascular causes of death, cancer, respiratory trauma, but none of them have been shown in any of the trials. So as of now, they only show benefit in terms of mainly vascular-related cardiac deaths. The next is plaque regression. Reduction of plaque lipid content, macrophages and inflammatory cells would mean that these plaques are regressing. And also increase in luminal diameter by an angio has always been a surrogate marker by angio, but now with a lot of imaging, we are able to get much more details. So we know that by imaging, a reduction in the total atheroma volume, reduction in the necrotic core volume, increase in fibrous cap thickness, and improvement in positive remodeling are all markers of plaque regression, and also change from non-calcified to calcified plaque. Now, they have been assessed by a number of imaging modalities. You have this invasive and non-invasive. The gold standard is IVUS, which is being used for a long period of time. Now, OCT has got advantages because it has got higher resolution, allows visualization of the thin cap fibrous atheroma, but yes, the extent of visualize is less, so you cannot assess atheroma volume. Then you have the near-infrared spectroscopy, which again helps us with semi-quantitative lipid measurements. Then of late, non-invasive methods have been validated. The CT coronary angiogram is come into prominence. Advantages being it can be non-invasive. We need not put in a catheter every time to try and assess the volumes. Then you have the PET scans where positron emission tomography. They have been emitting radioligands have been there which specifically go and target inflammatory cells. We are able to detect inflammation in the coronary arteries, and MRI scan. Then in IVUS, if you see over here, this is of the Japan study, you find that there's a reduction in the plasma, in the atheroma volume. Then this is where the virtual histology IVUS, again you find that the yellow is what you see is the lipid. You find that the lipid core has become less on follow-up and the lumen has become larger. In the IBIS-4 study, OCT shows that where the arrows are seen, you see that the fibrous cap has become thicker with treatment. And again in coronary angiogram, in CT coronary angiogram, again you find that the lipid pool has become less and the calcification has become more. You see that the white is the calcium, so the calcification is becoming more, showing that these plaques are regressing as such. Then these are some images where we can see there's an increase in the Glagovin phenomenon, what I told you about. Initially the vessel wall becomes enlarged and the lumen is maintained. Then you have the microcalcification. All these things can be detected with CT calcium, and this going in future, I think will have a role to play in how we monitor our patients and decide about what treatment they need to undergo. Now we have a number of statin-based regression studies. They induce plaque regression. They reduce total atheroma around 0 to 20% compared with around 10% increase in controls. Statin versus placebo trials and observational thing. In 1997 was the first time when they compared pravastatin versus placebo using IVUS, and they found that a significant reduction in the total atheroma volume among 36 patients, from -7% reduction in the atheroma volume in the pravastatin group versus a 41% increase in the control. So showing clearly that statin does have a role in regressing the atherosclerotic plaques. Then observational studies are there. Here the asteroid where the rosuvastatin 40 milligrams was in 570 patients at 24 months showed that there was a 6.1% reduction in the total atheroma volume. Cosmos and IBIS trial shared similar findings. The PREDICT trial, they compared statin in patients with and without diabetes, and they found that patients with diabetes had a higher or less effect of statin, giving us the idea that the comorbidities might influence how patients respond to statin. Then in coronary CT angiography, again, when it showed that in patients who had LDL level less than 70 had a much better response with statins as compared to more than 70. Now, high versus low intensity, you have the reversal, Saturn, Japan, all of them showing that higher intensity statin had a much higher regression of the plaque as compared to lower intensity statins. Statin trials and plaque composition. Another thing, whatever the newer imaging has shown us, is understanding the composition. There's an increase in fibrous volume and calcified plaque and reduction in fibrofatty volume, necrotic core and non-calcified plaque, increased fibroatheroma cap thickness, and also the lipid content. Now, what statin does is that it increases the calcification of, stabilizes the plaque. One of the mechanisms by calcification. It is thought that statins stimulate something called the M2 phenotype of macrophages, which actually promote macrocalcification as compared to M1, which promotes microcalcification and as plaque progression. Now you have OCT trials which have shown the same thing, fibrocatroma becoming lesser, thickness of the fibrocatroma increasing with statins. Then CCTA, again coronary CT scan also showing an increase in calcific plaque and showing plaque regression. So in conclusion, reducing plasma LDL cholesterol in a dose-dependent manner reduces the major cardiovascular events. Risk reduction is proportional to absolute magnitude reduction in LDL cholesterol. Statin-induced plaque regression is dose-dependent and proportional to reduction in LDL cholesterol. IVUS is the main modality to assess. Now, the CT angiography may have a large role to play because we can non-invasively assess who are the patients who have a vulnerable plaque and whom do we need to be more aggressive in treatment. So, future treatment may be guided by non-invasive plaque volume and composition assessment rather than surrogate markers like lumen diameter or LDL cholesterol levels. Thank you for your attention.